Hello, everyone. This is Susan, and I'm here with Erica. And we, in this podcast, are discussing sounds like a typical case of pelvic girdle pain in the pregnancy population. We put this case in there because she was really coming from somebody who had not really had good medical care for her pregnancy and pain up to the point that she came in to see me and was in quite a bit of chronic pain and was really just trying to live with it. This is a great podcast because I feel very strongly that all of us should be treating the pregnancy population, not just a specialized women's health group. Please go to iTunes and leave comments and questions. The other thing that we'd love for you to do is be able to rate us on iTunes. Every time we get 5s, it kind of moves us up on the mark. So we hope you enjoy this and let us know your thoughts.
Hey, Susan, how are you?
I'm good, Erica. How are you? End of summer.
God, the summer, for me, the summer went by very quickly because I moved, I think, and it just sort of, I don't know, I'm kind of happy, to be in some fall weather, actually.
Yeah, we're very blessed in the Northeast quadrant right now.
I know.
Especially after everything that happened in the Southeast. So
I know.
Our hearts go out to them.
Yes, yes.
We're thinking of you every day.
Yes.
Erica and I were just having a fun discussion, and we were just talking about one of the things we love about doing this podcast is it gives her and I just a scheduled opportunity to just really check in and visit about people that we have found challenging or a little bit tough to treat. And we're excited to always bring this next episode to you with the hopes that everyone out there listening is learning something new or thinking about something different to do with some of your clients that tend to take our emotional and physical toil sometimes when they come into our clinic. So
I know. And I know sometimes, we probably should do a podcast on something like this alone, as to how to sort of protect our own energy and protect ourselves from some of these people, because, that's a lot of, they're carrying a lot of emotional issues. And I had somebody last night who came in, it was quite late, and he was quite complicated. I'm sure I'll be talking about him at some point in the podcast, but I walked out of my office 2 hours later and I was completely spent. So that's another topic altogether, but that's, I think that's what's the beauty, and it's challenging, but it's fun, so looking forward to it. And I think, Susan, it's your turn to do a patient this week. And if anybody has any questions about any of the patients that we talked about, feel free to, once again, get a hold of us.
Absolutely. Shoot us an email, make a comment in the comment section. We'd love to hear from you. So yes, I think we should schedule a how to take care of yourself while you're taking care of the tough to treat, because we want to be healthy and energetic through our workday as well. We don't want it to be something that we're resenting or moaning about during our work life. We spend so much time at work that we want to be healthy and energized. So I'm going to launch right into my patient for this time. So we're going to take a little trek into something a little bit different, but it's something that I strongly believe that physical therapists, no matter what their background, if they're in the musculoskeletal world, should be able to treat the pregnant patient. And because there's so many people out there in pregnancy that are having back pain, pelvic pain, foot pain, hand pain, arm pain, neck pain, that many people are kind of like, oh, they're pregnant, I don't know what to do with that, so I don't think I should treat them. And or the patients are being told, across the board that don't worry, when you have your baby, the pain will go away. And actually, we know from statistics and epidemiology that if back pain and pelvic pain isn't addressed in pregnancy, at least 30% of them go on to have a chronic pelvic or chronic back pain following pregnancy. Wow, that's an alarming statistic to me, and it just means that we need to care for these women when they're pregnant. They're strong, they're resilient, they're not broken, they're just having musculoskeletal pain, and we should be equipped to be able to treat them.
Yeah, I had no idea the numbers were that high. Wow, that's crazy. 30%. Wow.
Yeah.
I don't see, I'm glad we're talking about this, because I don't see a lot of pregnant women. I see, postpartum, but I don't see many women who are pregnant. So I'm going to learn something from this today for sure.
This is kind of a fun subject close to my heart to talk to. And this was an interesting one because when she came in, it didn't seem like this was going to be very complicated. But as it goes, as we take a history and start listening to stories, you have to, find out what's really important to them and find out where you really need to work. So this one is a 28-year-old female who called me on a referral from another physical therapist. Kind of an interesting story. She is married to a hockey player who they both grew up in Pittsburgh, and they're home for the summer. This is where their summer home is between seasons. And most of the time when they have their health care, they have it through the hockey docs. You know, because they spend at least 9 months of their time, you know, with the team in the season. Anyway, they're back home, and he has a go-to physical therapist that he uses for his off-season training and work, and, you know, to heal up any injuries from the ridiculous amount of games they play. And called him because his wife was having, you know, these issues with back pain and hip pain. And as soon as they got back to Pittsburgh, he made the call to his physical therapist friend, who said, "Oh, let's get her over to see somebody who really knows how to treat this." So she called and was all in and made an appointment and came in to see me. Very, you know, 28 years old, 35 weeks pregnant. Wow. So she's, you know, delivery's going to be by July 1st.
Wow.
So, you know, she's, you know, and she had told me that she had been hurting since December.
Wow. And is this her first pregnancy?
This is her first pregnancy. And in pain since December. And so I just kind of asked her to just kind of sit back and just tell me a little bit about her story. Because her focus as she came in, and she says, "I have back pain. It's now in my pelvis. I've been told that my ligaments are too soft, that they soften too early. I have this rotation in my pelvis, so I think my pelvis is twisted. And I just had to live with this pain."
Wow.
And, you know, and I asked her, I said, "Well, before we even launch into your prenatal care, you know, where were you getting what have you been doing for your back pain? What's kind of been the story?" And she said it first came on when she went to go see, she was seeing a PT for her knee. And she started having some back pain that was developing. And so the PT that was seeing her for her knee said, "Oh, well, you have a twist in your pelvis." So they started trying to treat her for a twist in her pelvis, and her back pain got worse. And then the PT was kind of like, "Well, you know, I think it's because you're pregnant, and I really don't know what to do." And so there, she got the message that, you know, what am I going to do? There's nothing that can be done for that. And, you know, so she was also, you know, getting, she had a bit of a time with an OB when she first got pregnant. And so your visits are kind of, you know, far in between in the beginning, because it's not really necessary to see the doctor all that often. And they encouraged her to, you know, wait for her big follow-up appointments till she got back to Pittsburgh. Because they said at that point you'll need to establish with an OB who's going to be actually doing your delivery back home in Pittsburgh. At this point they were in Canada. But anyway, there was a long period of time that went between OB appointments, and she was just kind of relying on the, you know, doctors for the hockey team, which apparently a lot of women do that are attached to the team, which was, I found very interesting. So I told her, you know, it was interesting because she was like, "Well, what's going to happen differently than the PTs that I was seeing before?" And I said, "Well, before you were seeing people who were dedicated to the health of the elite male athlete." You know, that's pretty sports specific when you've got PTs that are dedicated to a hockey team. And I said, what you need is a PT that's dedicated to the women's health pregnant athlete. That's you. You know, so let's take a look at things a little bit differently, because you don't have ice skates on your feet and you're not, you know, playing a season. You know, what you're doing is you're getting ready for delivery and care of a new human. So she talked a lot about her fears, you know. Basically, she was really, really worried about the idea that somebody had told her that her ligaments had softened too early. And so her biggest fear was, what's going to happen with labor and delivery? How am I going to get through? If I'm having this kind of pain now, what's going to happen then? That was an interesting thing. She really almost wasn't interested in dealing with her back pain now. She was like really future tripping, really worried about what she was going to do when she got there. So a lot of the initial piece, I just had to kind of back down and kind of go with her, you know, a little bit about a trip of musculoskeletal changes in pregnancy and what we consider normal and what we consider common. And oftentimes back pain and pelvic pain can be common in pregnancy, but it doesn't have to be normal. And it shouldn't be something that she should live with. And she had been doing the thing like, I just was putting up with it. I was just blowing through it. I would just do do things because they hurt,
Yeah.
and I wasn't really paying attention that there was something I could do to make it better. I tried
Right.
to get a massage that didn't really help. It felt good at the time. It feels really good if I sit quietly for a little while, or if I particularly lay on my right side, it feels
Mm-hmm.
better. But
Yep.
every time I go to move, it starts to hurt again.
Right.
And so
And
she was just really feeling stuck.
yeah. And so the OB never really referred her for any kind of physiotherapy, right? I mean, do you find that that's common in that population?
I do find that it's common in the population. Many
Yeah.
times they'll just tell them that, and I'm not trying to throw the OBs under the bus at all.
Yeah. Yeah.
And they just haven't had great success with PT, except in
Right.
certain areas where they have a go-to PT that they know about that
Yeah. Yeah.
will actually do it.
Yeah.
So it's still a matter of education on our part with
Yep.
the physicians about what we can do. We're not just going to, rub their back and put some heat on them and give them 2 exercises. That we really are going to look at them from
Mm-hmm.
top to bottom and help them begin to understand how they can get some variance in their postures, and they can get some variance in their movement patterns that will take them out of their painful postures and painful movement patterns that they're kind
Yep.
of stuck in.
Mm-hmm.
It's always been kind of the human experience that when we lay down movement patterns, we kind of continue to move in those patterns even if they're painful.
Yes.
And so
Yeah.
sometimes it's like, we just need to teach her a new way to move.
Mm-hmm.
But
Mm-hmm.
before I could even get her attention to change that, I needed to help her understand what was going on,
Yeah. Yeah.
so that she would not feel worried. So we spent a lot of time talking about what was good. That she's strong,
Yeah.
she's resilient, her pregnancy has been going beautifully.
Mm-hmm.
She doesn't have any blood pressure problems. She's been eating well. Things are good. She's a very strong, resilient, young lady.
Yeah, those are the Sims.
Yeah,
The safety in
exactly.
me, right?
Exactly, Sims. Perfect. And the Dims are what's going to happen to me.
Yeah.
I mean, really, she was so focused on that future tripping, that addressing her symptoms right away wasn't going to get her to keep her coming in the door. I needed to address what she was really, really worried about.
Yeah.
So we talked a little bit. I said, there are things that you can do in labor and delivery, and we'll focus on those. We'll focus on what are the best positions, what can you do, what is how can you change and move around in labor and delivery so that you feel like you're protected and you're strong and you can do this. And so once I could kind of get her on the boat to understanding that she didn't have to, number one, put up with the pain. Number two, she didn't need to be worried about positional pain and making her pain worse through labor and delivery. And number three, that if we can begin to change things now, it's going to make your postpartum piece even better.
Yeah. Yeah.
And she's going to have some good information. And I encouraged her to, she had already signed up for, the pregnancy classes that you go to with your husband, where they teach you a little bit about what's going to happen in labor and delivery and the breathing and those pieces. And, then she started even asking more questions like, well, what if I decided to bring my husband in so that he could be part of this and see kind of what I'm doing too? I said, that's perfect. You need to gather your support system around you and be able to have those things. Because again, she's 35 weeks. So this little event could happen at any point. We'd love for her to wait till at least 40 weeks, right? Because that's the longer they cook, the better. But first babies, everybody often thinks they come early. They usually don't. They usually come later. And she's still got some moving and changing to go. So we talked a little bit about the rapid growth process and how that can begin to affect, just certain things that she does that, I said, the way that you move isn't bad. It's just that you're only moving in certain ways all the time. Your body is changing. So perhaps maybe some of your movement strategies could change too. And, get that going just a little bit better so that you feel like you're able to change in the moment. If something's hurting, you can change the way that you move to make it to something that isn't going to be as painful. Right.
It's almost like with these types of patients, you have to think on the fly a lot more often because with all the hormonal changes they're having, they're the potential, sources or causes of their issues can change along with them. So one day it could be this, the next day it could be this. So to have someone who's experienced with that population, especially when they've had such a long, many months of back pain, you need to be able to change with them and make quick not quick decisions, but you need to make sound clinical decision making, you know, and not just keep doing the same thing, because this person's changing in front of you. And if you don't change with them, then, you know, thou two shall never meet in the end, you know.
And
so I love it.
That's beautifully put, because they really literally are changing weekly. And particularly when they get into the last trimester, it's all baby growth, along with massive hormonal changes, because everything is getting ready now for the big event. And, you know, but the rapid growth of the baby moving straight out in front of the body, there has to be postural adaptations to that. It's normal. Otherwise, we're going to be pulled over onto our face. So, you know, being able to get her to be able to adapt quicker too was, you know, I felt like the key. But I needed to get her, first of all, I needed to get the buy-in. So helping her with her beliefs about labor and delivery, and that she had support, people, resources, understanding was key. So that was the good piece. Once she started to settle down about that, then she was able to kind of start talking about what was going on with her pain. And it was very interesting, because it was all or nothing that she would focus on. I either have all this pain all the time, or I can be here quiet and have no pain until I have it, and then it's all this pain all the time. So she wasn't listening to anything different. She wasn't able to scale, well, it's not as bad if I do this, but it's a little worse if I do this, but this is better. And you know, she was unable to kind of feel that. It was an all or nothing response, which I think is a part of that kind of just diving and pressing through it. And she called it, her words were soldiering on. Right.
And I think people do think that they need to live with pain, and that is, you know, maybe a belief, maybe it's perpetuated by society, but you don't have to live with pain.
Exactly.
You know, and
you have a pain experience, but let's figure out a way to change that pain experience.
Exactly.
So that you know when you're moving back into it or when you're moving away from it. Being able to feel that. So it was interesting, because generally my exam, and a lot of people's exam with pregnancy, is to look at the musculoskeletal system, do some of the normal things we would all do. I think a lot of people probably would maybe look in standing and kind of see maybe a bending over or not, you know, extension, side bending, those things. But generally, I think when people see pelvic pain and pregnancy or back pain, they want to immediately run to those lumbar special tests and those pelvic girdle special tests and put a belt on them.
Right.
Yeah, and that's a bit of what that is, what the evidence shows. So I actually I had her fill out the Pelvic Girdle Pain Questionnaire, which is validated on pregnancy and postpartum lady.
Okay. Yep.
And it's got what I like about this particular questionnaire is it's got some really good functional movements in there. And they asked them to grade those functional movements as to what they can do and what they can't do. And it was interesting, her history was an all or nothing. So was the Pelvic Girdle Questionnaire. But the cool thing was she really had to pick out the specific events that were like the ones that she graded the highest. So I could really see what was really the big things that were bothering her.
Interesting. Now, is that a specific questionnaire you made, or is that one that people can get generally?
No, that's one that people can get. And I'll actually put the link on the show notes.
Okay.
For the it's called the Pelvic Girdle Pain Questionnaire.
Perfect.
And it's full access. Anyone can get it and use it. And like I said, it's you know, it's validated for pregnancy and postpartum. And the link to it, I'll put in the show notes, but there's also the clinical practice guidelines for pelvic girdle pain in the pregnancy population. And the draft of that is on the Section on Women's Health website. And that's going to be coming out in publication this summer with the Journal of Women's Health PT. So,
nice.
So the stats on that Pelvic Girdle Pain Questionnaire is on there.
You know, it's funny. I have to renew my membership to the APTA this month, and I think I've never been a member of the Women's Health, so I think I actually am going to do that this year.
We would love to have you.
I will. Yes, I will be joining. Anyway, I digress. So anyway.
That's okay. These are good things. But I think sometimes when we look at all of these questionnaires and these outcome measures and all of these things, we almost become numb to them. Because, you know, okay, the oswestry, okay, the neck disability index. So, you know, but sometimes what I like to do with those is I like to look at those to help me develop what's important to the patient, because it gives me just more information. And with her, it was really kind of nice because it matched up exactly with what she was really worried about.
Yeah, that's
The
great.
things that she was telling me were the things that she had marked on the paper.
Yeah.
When you see the discrepancy, that's when you can get in and kind of question a little bit. Well, here you really indicated that this was a big problem.
Yep.
Well, maybe it's not as big of a problem as I thought when I filled that out. So these kind of start that conversation, but that I love them for that, because that kind of just helps me go, oh, but wait a second, what about this? You had talked about this on the questionnaire, but you didn't talk about it in your history. So tell me a little bit more about that. So kind of bring some more information in that way.
Yep.
So I decided to move a little bit differently with her. She was really having a lot of trouble standing, prolonged standing, walking, prolonged walking. The walking and the prolonged walking was what really brought her pubic symphysis issues on. Prolonged standing really brought on her posterior pelvic pain issues and some pain. She would like grab both sides of her hips. And, she goes, after a while, it just felt like I was in a vice here on both sides of my hips. So I looked to those things as the initial piece. Of course, moving in bed is always a big one. And getting in and out of a chair and up and down from the floor. So all of those transitional movements. But I just felt like, let's just start with standing, but let's do it in a little bit of a non-traditional way. Let's try to see if we can't get her in standing, and right away, I love the PT assess and treat, because we kind of do it all the time anyway.
Yep. So she had pain. I'm sorry. So she had pain right at the pubic symphysis as well as in the posterior. Okay, got it.
And so with the pelvic girdle pain, there's two bodies of evidence that have looked at that. One kind of classified it with Albert et al. And then Cook et al. Came in and kind of looked at their classification and even narrowed it down to testing that would be the most sensitive and specific. And they found that pointing to the pubic symphysis was as good as any test you could do.
Oh, wow. That's
as
great.
long as an important sign to the SI joint. And then also the idea of doing a single leg stance or a lunge. So a simple load transfer test. If it recreated that familiar pain in and around the pelvis, hips, or low back, that was really specific and sensitive too. And better than doing all of those cluster tests. So she's up and standing. I've got her. She's already pointed. So let's do a couple of those tests. So we did some load transfers.
Oh, nice.
To see. So I had her stand on one leg and, and had her stand on the other leg. And although she was wobbly, when she stood on the right leg, that did tend to increase her symptoms. When she stood on the left leg, not as much. So right away, I was getting her to tell the difference. This is different than that. Can you feel the difference? Those types of things. And then we did some simple lunges. And those brought on things, all around the pelvis, both directions the same. So right away we started working on how can we change this? How can you do that simple lunge and not have it hurt? And I just had her play around with, I gave her a couple of ideas. I said, try it turning your foot in slightly, turning your foot out slightly, try going in a diagonal, try a couple of things. So she started kind of beginning to play with movement. And by doing that, I'm still assessing, but she's also actually beginning to learn that if I move in a different way, I can change my experience. So she got to where she could actually do a 3/4 of a lunge on both sides without symptoms. And we're 5 minutes into the treatment.
How did she change that?
So all she did, she just, I just told her, I said, kind of think about widening your stance, bringing it in, turning your foot in and out, maybe taking maybe taking a smaller. And I let her play with it. And I just talked to her about, just feel the difference. It's, this and this, and it's not that this is bad or this is good. And she was kind of laughing a little bit because she was moving. I think it was because she just felt like she was safe. And so when she was able to actually lunge, she was so excited.
That's awesome.
I didn't think I could ever do this.
I
said, what do you think is the difference? So I did ask her, I said, what do you think is the difference? And she goes, I just feel like I can do it. I feel like I have confidence to do it.
Right. And because I think we talked about this the first podcast about changing people's center of mass and, a base of support, wide stance, narrow stance. And people don't realize, because it's the same motor pattern that they have. Like, I'll use myself as an example. I'm way over on my right leg a lot. And when I shift my center of mass over, you realize, I can do certain things better when I change, make some just postural adjustments. And I think people really know how to to do that themselves, but they don't do it because they're either not cute or they don't feel safe or they don't know, or they think it'll make them worse. And I really think that, I benefited just by listening to different ways that you have changed people's, just stances in straight sort of sagittal plane type tests. And then even with these lunges, and I always play with the center of mass, but I love the changing the base of support, whether it's a stride stance, a wide stance. And that's great. I'm all for that.
And it was just nice to have her, get the confidence. And I'll tell you, the old Susan would have immediately probably put a belt on her.
Yep.
And given her the stability that way. But what I'm really changing my approach and what I'm really wanting to do is empower the patient to be able, if I can get them doing a lot of things without a support system, I want to do it, because I know that even though they feel better with a belt, they're only likely to wear it under certain circumstances, because it's a little bit of a hassle to put on. You can't sit in it, and then you have to spend a lot of time trying on a whole bunch of other different, apparatus for pregnancy. She wasn't having the kind of pain that I felt like her whole abdomen needed to be lifted up.
Yeah.
And here's how I kind of figured that out. As she was doing some of her things, I said, okay, let's just go back to regular standing now. And I had her just do some easy sways and kind of just feel how that could feel and how she could change that up. And she could feel muscles turn on and turn off as she was doing that. And so all I did was I just came in behind her and I just lifted her, right underneath her abdomen, lifted the baby up just slightly. Mm-hmm. And I said, does that feel any different, than you doing this sway? And go ahead and do your lunge. Feel how that feels. I came in and supported it, let her do her lunge again. She felt okay either way. So I just didn't feel like right now we needed to spend a lot of time trying to lift the abdomen up.
Right.
Her belly is strong. She's got good tension and control through there, so I just said, this is not, I'm going to try to avoid support as much as possible for her. I didn't want to feed into that, see everything so soft and fragile, you have to belt it up. We may go there in a couple of weeks, I don't know, but now she was able to get herself out of pain. She was able to stand, she was able to lunge, and then we went into some squatting and some bending over. Mm-hmm. Functional movements. And so she learned a different way to squat and a different way to move. And then we took it into sit, and your big thing that I love is that sit to stand and watching the head.
Yeah.
Because I love, that was just so much fun when we did that the other day on the podcast, because I've gone back and done that with a number of my patients. And it's so cool because, I haven't really looked at the head as much as kind of what they're doing at the trunk, pelvic floor focus a little bit. And it's so, because it's like waving a flag.
I know.
Because the base is there. It's like, what's happening up above, that whole kind of thing. And it was like, oh my goodness, look at that. So I watched her head. I used your cue and I said, let's watch her head. And so she, was going in, and instead of focusing on her back, her pelvis, her hips, I used what I call my new Erica Malo trick, is I just where's your head? Here's center. Just let's stand up and sit down. Tell me where your head is. And she was knocking over, into my hand the whole time. And it was
that's crazy.
Such an eye opener for her, though, to see how much she was really tilting her, kind of doing things a little bit different.
Yeah.
So I just had her focus on her head. Yeah. And, I said, can you move your head in space while you're doing this? Move it away from where it's going. See if you can do it by moving it over the other way. She got busy doing that, and of course, then she wasn't having any pain with her hand, which was like, yay!
Of course. Yay!
It was just, I have to tell you, talk about taking care of yourself when you treat these tough people.
Oh my God.
When you have people laughing who were crying 15 minutes ago, and you're having fun because the creative process is coming out. Mm-hmm. And you're willing to look at things a little bit differently and change up the old exam thing.
Yes.
Then you can really start to have a good time. So within 30 minutes, I had her standing, squatting, lunging, sit to stand, doing the, getting things off the floor. We actually threw the shoes down and some stuff, so she had something to pick up. Mm-hmm. So we were able to, move through those things. So then the final thing was looking at the exam with her, getting in and out of bed. Mm-hmm. And I think at this point, that was another big piece of what I looked at, and then into the interventions that we'll do, that I did with her, and kind of how that all turned out.
I was just saying that, I think we're always trying to add new and novel, movements into the patient's nervous system. And I think just a different way of assessing, is new and novel. And the fact that you got her to develop her own strategy for squatting, for lunging, for standing, getting in on a bed, things like that, that's therapeutic in and of itself, the assessment, right? And the fact that you can affect a change that quickly, right? So,
Exactly.
and we talked about this before, and it's people just are like, well, then it's not my stiff joint, or it's not my, tight muscle. Well, at the end of the day, things are driving strategies, but if you can make a change that quickly, it really gets that buy-in. And with somebody like that, I mean, you got a lot done in that evaluation. I mean, that's a lot, which is great. But if you're finding, did you find that, with each functional movement, was it a similar change she had to make, or did she make different changes?
Well, what was interesting was the lunges and the squats and the bendovers were similar.
Yep.
And to me, I probably could have transferred that over to sit to stand, but I wanted to look at sit to stand just a little bit differently.
Got it.
And I'm not sure why I got there. Part of it was probably just being a little bit of influenced by, well, Erica's done this, I'm going to give that a try. But we had focused so much already on the back of the pelvis, and she got that, and she was feeling good. And I thought, let's do this a little bit different so she can begin to feel something above that pelvis and feel those connections up above, and kind of how that's happening. It just seemed important to start to bring in other parts of her body.
Yeah.
And so I loved looking at the head, because when you're moving in space like that, squat is a little different than a sit down, stand up. And I think it's because of how you're transferring your load back to the chair and back up versus a straight down squat, or one hand on your knee and bend down and pick something up. It's just, and with pregnancy, there's a tendency to fall.
Yep.
We have a high risk of fall in the 7th month on, and it's a it's an anterior posterior sway.
Yep.
So I just felt like, pulling that together, and then, thinking about the head, I thought, wonder what that head is doing.
Yep.
And so I just was looking at that observationally, not even thinking I was going to do anything therapeutic with it. And it just turned out, it was like, this is the cue. This is,
well, it's interesting. It's absolutely. And, just to recap a little bit, it's interesting. If you did not mention that she was pregnant, okay, you would see this type of evaluation you could do on anybody, really.
Exactly.
And you just added the fact that she was pregnant, and you modified a few things, but that's the beauty of an assessment like that, because you can do it with whatever population.
Right. And this is something anybody can do.
Exactly.
You can read and learn a little bit about pregnancy and the things and the red flags. It's easy. To find and pay attention to, and get that information. But these people are still straight up and down musculoskeletal people. And, the stuff that works for your chronic back pain, or your hip pain, or your knee pain, or your foot pain is the stuff that, you're going to do on this population. It's just some modifications. And, kind of understanding a little bit that this is that rapid growth of the belly.
Right.
And that they're going to change every week,
And I think that the cognitive barrier with a population like this is sometimes our own cognitive barriers, because we, as therapists, sometimes get very nervous about treating a pregnant woman, and you're like, if it's her first child, what happens? But I think we have to work on ourselves a little bit with populations like that. Get over yourself, it's, and you showed that beautifully in this assessment. So, and I think we can help these people, and we don't want to give the impression that they can live with pain, or they should live with pain because they're pregnant, because that is certainly not the case. And if we view them a little bit differently, differently as in the sense that you're pregnant versus you're a human being who has back pain, that changes your whole perspective on the person, right? So
absolutely. I think it's one of those things. One of my favorite quotes is, and I don't even know who said it, argue for your patient's limitations and they're theirs. Argue for your patient's expectations and it's theirs. So, when we, like you said, I love, if it's our hang up, make sure it doesn't become their hang up.
Yep.
You know,
Exactly.
if you need to inform yourself, inform yourself. There's so many resources out there. And I'll
Mhm.
put some of those resources into the show notes, as well as the Pelvic Girdle
Perfect.
Pain Questionnaire.
Yeah, that's
So
awesome.
people can read quickly, you know, on what they need to kind of watch out for and some myth busting and stuff like that. With that, we're going to sign off on part 1 of this particular podcast on Tough to Treat. We'll pick up next time with where we went with the rest of the exam and how the interventions have gone, and see what your thoughts are then on that. So
Sounds
this
good.
is Susan Clinton, and
Erica Mello. Enjoy the rest of your day.
have a great day. Okay,
Bye.
bye.